This next video will focus on the joint condition known as osteoarthritis, or OA for short. Osteoarthritis is not an autoimmune disease like the previous three disease states I've covered. However, it makes sense to include with some of these other diseases because of the fact that it also affects the joints of the body. Therefore, the end of this video will focus on some comparing and contrasting, primarily between OA and RA, but also between osteoarthritis and immune-related joint diseases. Osteoarthritis is a chronic degenerative joint disease that occurs without any kind of systemic manifestations of autoimmunity. It is characterized by loss of cartilage, new bone formation, thickening of subchondral bone within the joints, mild irritation of the synovial space, and thickening of the joint capsule overall. Osteoarthritis is by far and away the most common form of arthritis in the US. It affects at least 20 million people. Its incidence increases with age. By the time you get to age 65, up to 90% of people have at least some evidence of OA. At earlier ages, OA tends to be more common in men, and at older ages, it tends to be more common in women. OA is the leading cause of total hip and total knee replacement surgeries. OA is a multifactorial disease that is caused by direct damage to joints due to wear and tear over time. Either direct damage to cartilage, excessive mechanical force, or instability in the joints, especially in the load-bearing joints, results in damage over time that eventually presents as osteoarthritis. The single most significant risk factor for osteoarthritis is aging. The normal aging process decreases the quality and quantity of proteoglycans in cartilage, and this is the primary risk factor for the development of OA. In addition, other situations or conditions that either directly damage cartilage or produce excessive mechanical force or instability predispose to the development of OA. These include things like trauma, such as sprains and dislocations, mechanical stress due to athletics or occupation over a long period of time, other underlying inflammatory joint diseases due to infection, RA, or gout can predispose to OA, joint instability, which is primarily due to tendon or ligament damage, any sort of neurologic disorders that might cause abnormal movement, for example, diabetic neuropathy, congenital deformities like hip dysplasia, underlying blood or hormone disorders like hemophilia or hyperparathyroidism, and the use over a long period of time of certain medications such as colchicine, indomethacin, or steroids. In addition, obesity is also a significant risk factor for the development of OA because it puts excessive mechanical stress on the joints. Before getting into the pathophysiology of OA, it's important to review the function and activity of cartilage. Cartilage within the joints, for example, the knee joint shown on this image, is a smooth weight-bearing surface that helps dissipate mechanical stress across the joint. Cartilage is a specialized connective tissue made up of chondrocytes, which are cells that synthesize cartilage. These chondrocytes are embedded in a matrix of water, proteoglycan proteins, and collagen. The proteoglycans are the component that helps regulate movement of fluid in and out of cartilage, and collagen is what provides the tensile strength of the cartilage structure. Chondrocytes, again, are the cells that synthesize cartilage, and they are what maintain constant turnover of all of the components of cartilage. As long as all of these elements, chondrocytes, collagen, and proteoglycans, are functioning appropriately, the joint will be functional and healthy. The primary change observed in osteoarthritis is the loss of articular cartilage. The first thing that will be noticed is a loss of proteoglycans and collagen. These decrease naturally over time with aging, but their decrease can also be accelerated due to the risk factors I mentioned previously. There can also be some enzymatic destruction of collagen because collagenase activity, which breaks down collagen, is elevated in osteoarthritis. Also, in individuals with OA, we will typically see that cartilage is absorbing excess water, which makes it less strong and increases its squishiness, so to speak. The increased breakdown and loss of collagen can also result in the release of inflammatory mediators that can recruit a very minor localized inflammatory process. One important thing to note is that this inflammatory process is not related to autoimmunity. It's a local inflammatory reaction due to the damage, the structural damage occurring within the joint space. All of the changes I described previously result in thinning of the cartilage within the joint. This cartilage thinning leaves the subchondral bone unprotected, and the response of the subchondral bone is to become thicker and to harden so as to dissipate the mechanical stress across the joint better. This bone thickening and hardening can lead to the formation of bony growths at the joint margin, which are known as osteophytes. If osteophytes break off into the synovial cavity, this can lead to synovitis or some inflammation of the synovial fluid. The clinical presentation of OA includes the perception of an achy or throbbing pain in an isolated load-bearing joint, such as the spine, hip, or knee. This is typically asymmetric or involves one side of the body more so than another. And this is because OA is not an autoimmune condition. It is due to mechanical stress on joints, and more than likely, one side of the body received greater mechanical stress than the other. In individuals with OA, they feel joint stiffness, but this stiffness is usually short-lived because over time of moving the joint, it can actually feel a little bit better. Joint cracking is common, especially in the hip and knee joints. The individuals may have range of motion limitations and some possible joint enlargement or swelling, but this is much less common than with the autoimmune joint conditions. The primary affected joints are noted on this slide and include the cervical spine, lumbosacral spine, hip, knee, and interphalangeal joints of the hand. You can see the common signs and symptoms associated with each of these joints. The cervical spine is characterized by stiffness and possible pain in the arm that can be aggravated by moving the cervical spine area of the neck. The lumbosacral spine is characterized by pain in the back of the thigh along the sciatic nerve, muscle spasms, and a limited range of motion. When the hip joint is affected, the pain is typically localized to the groin or inner thigh, and the range of motion of the hip may be limited, resulting in a limp or shuffling gait and difficulty getting in and out of a chair. When the knee joint is affected, this can very commonly result in cracking or crepitus, and the knee joint is the most likely to crack when moving. This can also result in the appearance of being knock-kneed or bow-legged, depending on which way the knees lean. Knock-kneed would be knees leaning in, and bow-legged would be knees leaning out. In the interphalangeal joints of the hand, this can result in some deviation of the joints. Patient assessment for the presence of OA primarily involves findings on X-ray. Common observations with a joint X-ray would include joint space narrowing, which is indicated by the white arrow, osteophytes, which is indicated by the white triangle, subchondral bone thickening, which is indicated by the black arrow, and subchondral cysts, which is indicated by the white dot. You may also see some joint misalignment as well. It may be worth performing arthrocentesis or arthrocentesis to determine if there is inflammation in the joint space. Some minor inflammation may be observed, but this would be much less than that present for arthritis of RA or psoriasis or lupus. Blood tests do not result in any findings specific to OA, but may help exclude other arthropathies like the autoimmune arthropathies. This is an example of the criteria for the diagnosis of OA of the hip. For the hip specifically, the diagnostic criteria are hip pain and at least two of the three items identified there. An erythrocyte sedimentation rate below 20 millimeters per hour, which is in the normal range and suggests the lack of an autoimmune or inflammatory condition. X-ray evidence of osteophytes or X-ray evidence of joint space narrowing. In terms of the prognosis for patients with OA, unfortunately, OA is one of the top 10 causes of disability among adults in the US. It's actually the number one cause when combined with other arthritides. Complications include possible joint deformity, loss of flexibility, or muscle atrophy due to limited use. OA can also limit physical activity, which can result in downstream effects like obesity. For monitoring patients with OA, it is important to monitor joint space narrowing, as this can be linked with more advanced disease. Appropriate treatments, however, can reduce pain, maintain mobility, and limit disability in this disease. Here I'm showing a comparison between some of the characteristic features of OA and RA. OA is common in the elderly, and aging is the single biggest risk factor. It commonly presents asymmetrically in weight-bearing joints such as the knee, hip, and spine, and is associated with no systemic effects or evidence of inflammation. In contrast, arthritis of RA is much more common in middle age and presents symmetrically across the body. It is more common in non-weight-bearing joints of the hands, wrists, and feet, and involves signs of systemic inflammation, like elevated ESR and CRP. The graphic on this slide depicts visual differences between OA and RA. In OA, you will see thinned cartilage and bone ends that rub together. In RA, typically the bone ends do not rub together and the cartilage actually looks relatively normal. However, you will see things like bone erosion and significant swelling and inflammation of the synovial membrane. I will not go through this table in detail, but I wanted to present it to you as a way to help distinguish the features of OA from other causes of chronic knee pain. For example, rheumatoid arthritis or gout, which are the two most common other arthritides that would affect the knee joint.